Illinois Stories is brought to you by the Corporation for Public Broadcasting, Illinois Arts Council Agency, and by the support of viewers like you. Thank you.
Hello, welcome to Illinois Stories. I'm Mark McDonald in Quincy at Blessing Hospital in one of the standard operating rooms. Unless you're a surgeon or a nurse or a technician, the odds are you may never see an operating room like this. Even patients are usually unconscious by the time they get in here. Now, I want you to take a look at the dimensions and the way this room is equipped and hold that in your memory, because the purpose of this story is not to show you this operating room, but to show you the new operating rooms here at Blessing, the multi-purpose room and the hybrid room. They are quite different. Dr. Harsha, starting in February this year,
Yes.
Blessing opened these two new operating rooms. And for someone like yourself, who this is their place, this is where you live, this is a big deal, isn't it?
Yes, yes. Having this room is extremely helpful for us, especially this provides, number one, added room for us, for the surgeons to operate in, as well as the much needed space that we needed to the operating room. As you know, Blessing health system is becoming a regional player, especially in the trauma area. We're seeing more and more traumas coming our way, which means we need more room in the operating room, and this clearly helps us out with that.
We call this the multi-purpose room, right?
Yes.
And what would happen here is if you had a trauma case where you had a patient with multiple issues,
Yes.
you could have yourself, who's a colorectal specialist, and you
Yes.
could have a heart specialist, and you could have a plastic specialist. You could have a number of specialists working in the room at one time. And is that why you need to have a bigger room?
Yeah, mainly somebody who comes in as a trauma patient, they usually have multiple injuries and more than one specialist. It could be orthopedic surgeon and a general surgeon, or a plastic surgeon who needs to work on the face. So we can all work together in the same room, because this room provides the necessary room for the equipment and for the surgeons to operate at the same time.
Would you walk us through and show us the key equipment that's in here that you need?
Absolutely, absolutely. So the main thing here is the anesthesia equipment is right here. As you can see, this is where we have all the medications as well as supplies to put the patients to sleep. Once the patient is asleep, and we use this bed, or we can change it to a different bed based on the needs of the patient to actually perform the procedure. And as you can see, we have these new lights here with cameras inside the lights. So when we're actually operating, we can project the image.
So is this where the camera lives up here? Okay, and then these lights, of course, provide, you can see there's dozens of lights, so it provides a lot of light, but the cameras are here.
Yes.
Okay.
And this camera projects the image onto the TV here. So if there are any students or anybody in the room, they can use it as a learning experience, either nursing students or medical students, or anybody who wish to watch the procedure. In good olden days, we used to have the students come in and watch the procedure on top of the surgeon's shoulders. Now we don't have to do that anymore with this equipment.
Right, and that can be a distraction. You're a surgeon yourself, that could be a distraction, I guess. And you want that space.
Yes, not only distraction, we like our sacred space, just to prevent any surgical infections or anything like that. So,
is there anything besides the anesthesia to point out here that we need to know? What are those different colored wires that go into that contraption there?
So those wires are the medications that are required, or the gases that are required to administer anesthesia, as well as to help patients breathe normally. And as you can see the boom on the ceiling. What it helps is we can rotate the beam to the opposite end of the room. So if we need to flip the patient where the head end of the patient needs to be on the opposite side, then we can easily do that with this equipment.
I see.
And we don't have the technology in other rooms, and that's why we really love this for our trauma patients.
Does it get used frequently?
Yes, very often.
And have you ever been in on a case here where you had a patient, say a trauma patient, that had 2 or 3 different physicians working at this?
Absolutely.
Oh, you have?
Yes.
It's not
Yes.
that rare, huh?
Yes.
Unfortunately.
Yes. Yes.
Usually car crashes, or what sort of situations might?
Most commonly, we see either car crashes or ATV accidents, or farming accidents is what we see here in this part of the world.
Well, it seems to me that that with the added space here and with the added capabilities that you have and the added learning abilities that you have here with this, it's an upgrade, isn't it?
Absolutely, absolutely. And as you can see here in front of us, all the supplies are stocked in this room. So if the surgeons need any equipment, they have them right here in the room, as opposed to walking out of the room to get those supplies. So that adds a lot of efficiency into the system as well.
Well, Doctor, thank you. Appreciate it.
Perfect.
Yeah, thank you.
Thanks.
Dr. Tim Smith, it's been told to me that you were more than a little bit responsible for getting this hybrid room built. And when you walk in here after years of thinking about this and trying to coalesce support to get it done, what do you feel like when you walk in here?
Well, it's wonderful. I remember during our training, having cassettes slipped under the patient and having an x-ray, and then we've moved on to live imaging, and we've always had the live imaging, but we see that the better imaging you have, the more that we can do safely. So maybe 15 years ago, I said we need a hybrid room. We need a room with sophisticated imaging in a sterile environment. So over time, I was told it's going to happen, and then maybe it's not going to happen right now. And then I was told it's going to happen again, and well, not right now. We get to maybe wait. So it took a while, but yeah, it's a great feeling. I'm just so pleased with Blessing having made that decision.
Yeah. Can we walk this way? And I want you to show me the arm. And first of all, why do they call it a hybrid room?
Hybrid room, as you know, we think about like cardiologists put in stents, and they do a lot of interventions. We have the same equipment now inside of a sterile environment, inside the OR. We don't have to roll in a X-ray unit that's portable. This robot arm, which is
that's what we're looking at here. This is the robot arm.
This robot arm. It's designed after the Mercedes assembly line robots, and they make cars in Germany, so it's a German equipment. But it parks itself in the corner. So a lot of the design time, it took 2 years to design this room, and we had to decide: do we want this here? Do we want it here? So we went to Champaign, Illinois. Went to several large hospitals, and just to see how they were doing it. And we got a lot of different ideas, and we decided best place is to park it in the corner, which it could just fold itself up. And then when we need it to come over the patient and hover over the patient, then we bring the camera in and do our procedure.
And so the hybrid means that you're ready to do what you would do in a cath lab, but you're also ready to do what you might have to do in an operating room?
That's right, because a lot of what I do is I may have an incision, an open case, but I need to also do a dye test as part of the procedure. So, for instance, if I'm fixing an aneurysm, well, I have to make a 1-inch incision in the leg, something you really don't see in the cath labs, or I may have to do a full bypass of the leg. So, part of the procedure is threading a wire through an artery and putting a stent in, whatever we have to do, combined with an open procedure.
One other thing you notice about this room as you're in here, you notice that it's very large. Now, is it only large because it has to accommodate this arm, or is it large because it has a lot of other additional equipment in it?
Yeah, that's probably the best thing about this room is it is so large, and of all the places we visited, we've never seen a room this large. So we feel really lucky in having the space, and having the equipment in the background, all the stents, all the equipment we need in the cabinets that are in the room and not outside of the room.
Right, so you don't have to run errands. I mean, it's right here.
That's
isn't it?
That's all our balloons, our stents, everything's here.
Yeah.
So it's we're really lucky to have such a large space. If you But walking more traditional OR, you would really notice the difference.
Can we walk back around to where you work? When you're operating or when you're doing a procedure in here, you're on this side of the table more than likely, right?
Right. I have, for instance, I'll have the controls where I could put it here on the rail, and then I'll be able to manipulate the table if I go up or down on the table. As far as the arm, the radiologist or the radiological tech, but I can also drive it, put it where I want to over the patient. And then we have, of course, the large imaging where I have a live image, I'll have a reference image, I'll have the vital signs in the lower section, or I can have just one large screen, or I can have 8 screens. I can have old films up, I can have a lot of things up.
Do you call for that during a procedure and somebody in the control room does that for you, or do you have control over all that?
Right, in the nurse's station back there, we can set up anything that we need. If I want a live image here and an ultrasound image, I'll be scanning the artery with an ultrasound, putting the catheter in at the same time I'm fluoroing, and I have another screen where I'm watching the fluoro.
Does this get used a lot?
Get used a lot.
Yeah.
The nice thing about having a room like this is that we really attract some talent here, some young talent. So we just hired a new vascular surgeon, and now we have these young guys coming out of training because they are used to doing cases in this type of room. They're doing cases like a cardiologist would do, putting stents in, doing some very neat cases. And we just wouldn't be able to attract that talent without this room. And that was really, I think, a point of interest to the hospital. And it's like, well, we can have people here that are young and used to doing it.
How many years do you think you were desiring this room? When did you plant the seed? 20 years ago?
Yeah, 20 years ago. I've been here 21 years, so it's been a long time.
Yeah. Well, congratulations.
Thank
I bet you when you walk in here, and you probably have a feeling of confidence, and the fact that what the heck, nothing can go wrong. I mean, we've got everything we need, right?
Right. Yeah, it's great. And they asked me what room number we wanted, 10 or 11 as well. My granddaughter's born in 11/11, so I said,
So this is number 11?
Even got a say on the room number.
Thanks, doctor.
Yeah, thank you.
Okay, Nick. Now, in this hybrid room, one of the great upgrades that was available was it's a new way to provide imaging for the doctor while he's working on the patient, right?
Right.
And you control the imaging.
Yes, I control a good part of it. The doctor controls the actual exposure of fluoro, but over here we have the ability to, once we acquire images, we can post-process them to sort of bring out areas of interest. We can magnify areas that might be of concern. If we are using contrast, which is a dark medium that is darker than the vessel around it, we can use that to see if the vessel might have an aneurysm, if there's any leakage around a stent that we put in, or any other issue with the vessel. Allows us to diagnose stenosis and then treat it in the same procedure rather than having to do a procedure outside of the OR and then bring them back in a future date.
Oh, okay, so in the old days, it's very possible that you might have identified something, but you don't know, so you have to go get imaging and then bring the patient back again. And this way, it can all be done in one room at one time.
Right, depending on the severity of whatever we might diagnose. But in some cases, we're able to then treat something very quickly rather than having to bring the patient back at a later date.
Can you show us how it works?
Yes. So the machine's basically, it's a traditional X-ray C-arm, which is sort of the workhorse X-ray unit in operating theaters. It's attached to a robotic arm, which is very similar to the kind you might see in a manufacturing plant. This entire equipment is also smart. So the C-arm knows where the table is and the floor and ceiling and walls. So you can't really get it to hit any of that. So normally in a case, we'd go ahead and bring the C-arm in over here over the table. So the patient would be laying with their head furthest away from us, feet towards us. And once we're over the table, there's a couple different ways we can adjust the imaging or move the patient. So we could, for example, release the table and move the table forward and backwards. We can also just move the C-arm itself forward and backwards. Sometimes the patient's position in a surgery case is usually fixed. So to see some anatomy, we might have to rotate the C-arm to one side or the other. Like so.
So you don't have to turn the patient. You can just make that turn around the patient.
That's right.
Okay.
We can move up and down. And we can sort of come in from different directions as well. If we need to work, for example, on the far side of the table here, we can adjust the C-arm so that it comes more on this side, allowing there to be more space on the table.
Now the arm, and I'm going to go point at this now, I'm not going to touch it, but the arm has some kind of a vision or some kind of a, what signal's coming out of the bottom that it's reading on the patient here?
For the bottom of the machine is emitting X-rays. Those are detected there's a detector on the top plate. So the X-ray, in a normal X-ray machine, the X-ray would come from the top down. In a C-arm like this, it comes from the bottom up. So essentially, because of geometry, we can do things like this. By bringing that closer to the patient, we reduce what's called magnification of the X-ray image.
And is that why we wear lead in here?
Yes.
Okay.
Anytime we're using radiation in a surgery case, we encourage everybody in the room to wear lead. If we have a patient of childbearing age, if we're able to, we would shield them as well, and make sure that we don't have any unshielded pregnant people.
And of course, the patient is also, could be, a subject of too much of that too. So that's what that's for.
Yes.
Now, would this be an example of what the doctor would see when you're providing images for him?
Yeah, this would be a perfect example. So in this particular image, we're looking at contrast, which is the dark flowing material, and that's actually in the abdominal aorta. In this case, the patient's already had a stent placed, this is actually an endovascular aortic graft, and the contrast is you can see contrast flowing down into the two larger arteries that feed off of the main aorta into the legs. And the wiry substance is the wall of that graft and stent that they put in.
So to sort of summarize all this, what this allows the surgeon to do, or the doctor to do, is to make sure that he can do all of this in a timely way without having to have the patient leave the room for imaging and come back and then continue to do the work they're doing. They can get the imaging done here all in one time.
Yeah, well, in particular, it allows us to image before we begin doing procedures, and then we can use that imaging to enhance our procedure too. So, for example, we could take this image and stop it at a point where we see contrast filling up the vessels. And what that would allow us to do is there's a feature that would allow us to turn the dark contrast white, and then we would be able to see a wire or a catheter or something else that's being fed up through the vessel more clearly, and see that while still being able to see the contours of the vessel.
Gotcha. Dr. John Hammock, for people who know what a cardiologist is, but they don't know what an electrophysiologist is, what do you tell them?
Well, I did my cardiology specialty training, but I also did extra years in cardiac electrophysiology to specifically work with heart rhythm disorders.
Okay, so if I have an arrhythmia, or if I need a pacemaker, or that kind of thing,
Correct.
That's where you come in.
That's correct.
Okay. Now, you need special working conditions to do that too, don't you? You have a special lab just for that kind of work.
I do. We have a separate electrophysiology lab where I use it almost every day. I put my regular pacemakers, defibrillators in those labs, but I also do work by getting rid of heart rhythms in that other lab, where we go through the process of figuring out where the problem is occurring and either burning or freezing that abnormal heart rhythm.
But there are times when this new hybrid lab is perfect for you because you have specialized procedures where you need to be able to perform surgery or have a surgeon present just in case, right?
That's correct. One of the greatest things about having this room available here is that I can do laser lead extractions of old pacemaker and defibrillator leads. That is a complex process that requires two separate subspecialties, electrophysiology and potential open heart surgery. And so when we do the pacemaker lead extractions in here, we have two tables open. One is the table that I'm working at to take care of these old pacemakers and get the leads out, but I also have a whole open heart table open with the cardiothoracic surgeon standing in the room, in case there is a problem that would require us to go to open heart surgery.
Wow, has that happened recently?
It's never happened to me.
It's never happened to you, and you pray it never does.
That's
right?
correct,
Okay.
but you always plan for the worst.
Yeah, well, that's great. So here you have a heart surgeon on call, actually not on call, but in the room.
Correct.
In case those leads don't come out the way they should.
That's right.
So that's quite a step up, isn't it?
It is, and it was something that I was trained to do, but until we got the room, I wasn't willing to do it unless we had the right circumstances and settings.
Yeah. Well, thank you, doctor.
Certainly.
Maureen, describe the process, the thought process about why these new operating rooms were needed, and then a little bit about the process of actually obtaining them, because it's a big deal, isn't it?
It's an unbelievable deal, and I would say the process started with our surgeons, talking about where technology was going in the future and how we needed to position ourselves as a healthcare system in the community. And sometimes you need the stuff before you have all of the doctors who are here to do it. And the newly trained surgeons are coming out trained to do minimally invasive surgery, and they need a lot of imaging technology to support them along the way. So thus the hybrid OR. When you look at the other multi-purpose room that we built for trauma, we are a regional trauma center. We are getting people flown in here. The helicopter is bringing more in over the last 2 years than we've seen in a long time. And we've got some excellent trauma surgeons here. We have 2 general trauma surgeons, and all they do, they are here every day waiting for that trauma case to come in and able to respond. And then we have 2 orthopedic trauma surgeons, again, on deck every day, general surgeon, trauma surgeon, waiting together to be able to address the needs of the community. And what that's done for some of these outlying regions, if they only have 1 orthopedic doctor or they have 1 surgeon, they can move the patients from these critical access hospitals, 75 miles away into us, and we have an orchestrated team ready to take the patient. And then we communicate back to that facility, and we'll send that patient back home to their community so that they can get their continuing care, whether it's therapy that they may need for their ongoing recruitment or improvement in their health.
Yeah. It's a time-consuming thing. You don't just start out by planning, next year let's open these operating rooms. There's a period of money's always an issue. How much is it going to cost? How much planning goes into it? You have to get all kinds of licensing permission from the state, don't you?
Absolutely. It was about a year in the planning process getting this done, and really involving the surgeons. They went out and did site visits at different facilities to say, okay, let me see what you built. Now tell me, if you could do this again, what would you do different? So that we could learn from their experiences of what is working really, really well and what needs improvement. And then you have to have everybody build consensus at a table of this is what we want to draw our box to look like. And as individual persons, we all have strong opinions.
Sure.
But those surgeons sat down and developed what I think, and you saw it, a state-of-the-art facility for our patients in this region to get care.
What do the surgeons say now? Do they say, I wish we'd done that? Or are they saying, this is just right?
Right now, we're hearing
It's
this
just
is
right?
just right.
Okay.
But let me tell you, technology is changing every day. And there is going to be something new that is coming into this field of specialty. I was at a meeting last week, and it's not about surgery, but I actually saw a physician hologram. And they are taking telemedicine and bringing in a little bit of that Disney technique. And so instead of you seeing the doctor's picture on a computer screen, the whole body of the physician came in the room, and the physician was talking to the patient as a hologram. And I grew up in the era of Star Trek, and you saw some of this, and if you ever go to Disney, you see these holograms. It was pretty cool to see what's happening. I can't imagine what that technology is going to cost. I don't think that hologram can operate, though. I still think, but that's where we see robotics. And we have robotics up there in surgery as well.
It's
We have
okay.
the
If it's
Da
my
Vinci
choice,
robot.
I want one of those surgeons I just interviewed, I'll tell you that.
Aren't they special?
Yeah. But, you still need more surgeons, you need young blood, and actually you need to have facilities like this in order to recruit and then to keep the people that come, don't you?
Absolutely. And you know, Quincy is this great town. If we can get a physician to this community, it is amazing the feeling they get when they get here. If they just look at it on paper and they look at the map, they're going, do I want to come here? But when they see what we have, from the education we have for kids, to sports, to theater, to the arts, it is amazing what's in this little gem of a city here. And they come in and they see that they can have both the professional and the personal life that they want to have for their families. And yes, we need some young blood. We're all getting a little bit older. And so we've got to find that blood to come here and join some really experienced surgical specialties here in our community, and so that they can pass the torch when they're ready to do so.
Well, thank you, and to your surgeons for allowing us to come in. It's always disruptive to have people who, aren't used to being in the surgeries, a photographer and a reporter come in, and we appreciate it very much. Thank you.
Well, thank you, and we appreciate you telling our story and recognizing some of the accomplishments of the surgical team we have here at Blessing Health System.
Back in the multi-purpose operating room where we started this journey, you may be wondering how often these 2 new operating rooms get used. Well, opening in February, each one has been used more than 400 times this year, some 5 to 8 times a day. With another Illinois story at Blessing Hospital in Quincy, I'm Mark McDonald. Thanks for watching.
Illinois Stories is brought to you by the Corporation for Public Broadcasting, Illinois Arts Council Agency, and by the support of viewers like you. Thank you. For a DVD copy of the program you've just seen, send 1995 to P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.